Imagine walking into a doctor's office, right? You have this lump on your thigh.
Mm-hmm.
And it's been there for a few months, maybe even a half a year. But here's the catch. It's completely painless.
Right, which is usually when people ignore it.
Exactly. You don't have a fever, you haven't bumped your leg, no car accidents, no trauma at all. And you look down and the skin over the lump is, well, it's totally normal.
No redness, no inflammation.
Right. It doesn't look angry. It's just been growing very slowly, very quietly, right under the surface. And honestly, perhaps even a busy doctor looking at it during a quick 10-minute appointment might easily dismiss it.
Oh, absolutely. They might just think, oh, it's a lipoma.
Yeah, just a harmless, benign little collection of fat cells. We all get them as we age, so no big deal, right?
And that assumption is exactly where the trap springs shut.
Ooh.
Yeah, that single moment in the clinic,
Yeah.
that's the critical point of divergence in a patient's life. Because hidden inside that seemingly innocent, painless mass could be one of the most deceptive and high-stakes tumors in medicine.
A soft tissue sarcoma.
Yeah.
Exactly. A soft tissue sarcoma.
Which brings us to the mission of today's deep dive. We're looking at a comprehensive, clinically rich review, essentially the masterclass curriculum that bridges basic medical school knowledge with advanced surgical oncology.
It's an incredible document.
It really is. And we want to decode this disease for you. We're going to transform this dense medical subject into a biological detective story. We'll unpack how a harmless-looking lump pulls off this brilliant disguise.
We'll get into the microscopic genetic typos, the physical exams, and the really high-wire surgical strategies used to defeat it.
Right. So to really grasp why a soft tissue sarcoma is so dangerous, we have to start with the basic architecture of the human body.
We really do. We have to draw a hard line between two main categories of solid tumors. You have carcinomas and you have sarcomas.
And clinically, they behave like entirely different species of disease, right?
Completely different. The definitions say carcinomas arise from epithelial tissues, while sarcomas arise from mesenchymal tissues. Okay, but if you aren't a doctor, those words don't mean much. So let's build an analogy for you to visualize this. Let's imagine the human body as a house.
I love this analogy.
Right. So if the body is a house, the epithelial tissues, the ones that cause carcinomas, they're the wallpaper. They're the paint on the walls, the shingles on the roof, the protective tiles in your bathroom.
They're the linings.
Exactly. Your outer skin, the lining of your lungs, your stomach, your colon, all epithelial.
And if we think about the life of a lining or a covering, it's a life of constant exposure. It's constant damage.
Like shingles getting hit by hail.
Right. Or UV radiation.
Biologically, your epithelial tissues are constantly subjected to friction, stomach acid, smoke, the sun. So they have to constantly turn over.
They're rapidly dividing to replace themselves every single day.
Exactly. And every time a cell divides, there's a chance for a copying error in its DNA, a mutation.
Because they divide so fast and face so much abuse, they mutate constantly. And that's why carcinomas like breast, lung, colon, and skin cancer make up the vast majority of human cancers. But then we look deeper, past the wallpaper, past the drywall, down to the mesenchymal tissues.
The structural foundation of the house?
Right. The thick wooden beams holding the walls up, the plumbing, the electrical wiring, the fiberglass insulation packed between the studs.
So biologically, we're talking about skeletal muscle, deep fat stores, fibrous tissue, blood vessels, nerves, and the synovial tissues in your joints.
Yes. And because this structural foundation isn't exposed to the outside elements, those cells aren't constantly dividing. So mutations here are incredibly rare.
Less than 1% of all adult cancers, right?
Less than 1%. But the rarity isn't the most important feature. What matters is why this structural origin makes the disease so deceptive.
Because mesenchymal tissue is literally everywhere.
Exactly. You have blood vessels and fat and connective tissue from the top of your head to the soles of your feet. A sarcoma can originate almost anywhere.
And they're deep. Like if you have a carcinoma, a wallpaper cancer in your colon, it bleeds into the digestive tract pretty quickly.
Right. You notice blood in your stool. Or if it's in your airway, you cough up blood. The surface tumors sound the alarm early.
But a sarcoma doesn't do that.
No. Imagine a tumor starting deep in the thick muscle belly of your thigh. Skeletal muscle is soft. It yields to pressure. The deep fat compartments are designed to act as expandable cushions.
So when these mutant cells start forming a mass, it doesn't hit a solid wall right away.
Exactly. It just slowly pushes the soft muscle fibers aside. It's insulated by the body's own architecture.
It grows silently. The house is just like accommodating the new addition without cracking the foundation.
Which brings us to the geography of this disease. Knowing they emerge from deep structures, where do they usually show up?
The clinical maps say about 60% occur in the extremities, the arms and legs.
Hmm.
But the absolute most common site is the thigh.
Structurally, the thigh makes perfect sense. It contains the largest, thickest compartments of skeletal muscle and deep fat in the human body.
Right, the quadriceps, the hamstrings. It's a massive reservoir of mesenchymal tissue.
It's the thickest structural beam in the house.
Mm.
So statistically, it just provides the most fertile ground for a random mutation to occur.
They also show up in the upper limb, the trunk, the head and neck, and this really tricky area called the retroperitoneum.
Oh, the retroperitoneum, that is the deep cavernous space in the very back of your abdominal cavity, behind your stomach and intestines.
Right against the spine and kidneys, a tumor can grow to the size of a melon back there before you even notice your belly protruding.
It's terrifying.
Yeah.
And within all these locations, we see a vast catalog of subtypes. The medical names actually tell you which building material went rogue.
Right. So liposarcoma is cancer from fat cells, the insulation.
Huh.
Leiomyosarcoma is from smooth muscle cells.
Fibrosarcoma from fibrous connective tissue. Rhabdomyosarcoma from skeletal muscle, the actual mechanical beams.
Angiosarcoma from the inner lining of blood vessels, the plumbing. And malignant peripheral nerve sheath tumors, which come from the myelin coating around your nerves.
The insulation on your electrical wiring. We also have to mention synovial sarcoma.
Named because it often occurs near joints, right?
Yeah, early physicians assumed it came from joint lining. But the cellular origin is actually a bit more mysterious. And finally, there's undifferentiated pleomorphic sarcoma.
Pleomorphic just means taking many forms, right?
Exactly. The cells have mutated so many times, their DNA is so chaotic that pathologists can't even recognize the original building material under a microscope.
Mm-hmm.
It's just an unidentifiable aggressive mass.
It's the ultimate disguise, which bridges perfectly into the sheer danger of misdiagnosis.
It's a huge problem. Because they arise from deep tissues and grow slowly, they mimic everyday benign conditions.
Like a lipoma, or an organized hematoma from a sports injury, even a deep bacterial abscess.
So doctors are faced with a dilemma. You can't surgically remove every single bump and bruise a patient comes in with. That would be absurd.
You need a filter, which is where medical training provides the red flag features, traits that scream danger.
Right. First is size greater than 5 centimeters in diameter. Second is location if it's deep to the deep fascia.
The deep fascia is that tough, silvery connective tissue that shrink wraps your muscles, right?
Exactly. If the lump is beneath that shrink wrap, red flag. Third is rapid growth. Fourth is if it feels firm rather than soft and squishy.
And mobility if it's fixed to deeper structures and doesn't wiggle when you push on it. Plus, if a lump was removed and grows back in the exact same spot, that's a massive red flag.
Okay, wait. I need to pause here because there's a glaring contradiction. The clinical criteria list pain as a red flag.
Yes.
But when we started this deep dive, we painted a picture of a patient with a completely painless lump. How can both be true? Is it painless or is pain the red flag?
That is the perfect question. It gets to the heart of this biological detective story. The short answer is both are true, but at totally different stages of the disease.
Oh, okay. Walk me through that.
Think about how the tumor grows. It starts microscopic, deep in a yielding muscle belly. As it expands, it just gently pushes normal tissues out of the way.
Because the muscle is compliant? Right. For the first few months, or even years, this expansion doesn't trigger any pain receptors. It's completely asymptomatic. That's the painless lump you feel in the shower.
So it only becomes painful when it finally runs out of easy room to grow, when it hits a wall.
Exactly. Pain develops late. The tumor expands until it hits that tough, unyielding deep fascia, or it presses against the nerve-rich lining of a bone.
Or it starts crushing major nerves or blood vessels.
Yes. The pain isn't usually from the cancer cells themselves. It's the collateral damage of a massive object, creating extreme pressure inside a closed compartment.
So a lump that starts off painless, sits there for months, and then slowly becomes painful. That's a blaring siren.
It means the tumor has maximized its local real estate and is now invading vital structures.
Wow. Which brings us to the golden rule of clinical practice. Any soft tissue lump bigger than a golf ball, which is about 5 centimeters and deep to the fascia, must be considered a sarcoma until proven otherwise.
You absolutely do not assume it's just a pocket of fat. You assume the worst case scenario.
And that caution is driven by what's happening deep inside the cells, which leads us to the genetic blueprint. Where do these sarcomas come from?
Well, the clinical data notes that the vast majority are sporadic. Just bad luck. a random copying error in a cell's DNA over a lifetime.
But there are risk factors, right? Like previous radiation exposure.
Yes, it's a cruel irony. A patient might be treated for breast cancer with radiation, and decades later, the connective tissue that absorbed that scattered radiation mutates into a sarcoma.
There's also chronic lymphedema, which is severe long-term swelling, often after removing lymph nodes. That can lead to a lethal sarcoma called angiosarcoma. Chemical carcinogens play a role too.
But where the science gets truly fascinating is the inherited genetic syndromes linked to sarcomas. It's like looking at the exposed wiring of human biology.
Let's talk about those. The literature highlights three major syndromes. First is Li-Fraumeni syndrome, caused by a mutation in the TP53 gene.
Ah, TP53, the guardian of the genome. To understand Li-Fraumeni, you have to know what P53 normally does. It's a tumor suppressor gene.
It's basically the emergency brake and quality control inspector for your cells, right?
Exactly. In a normal cell, if DNA gets damaged by a chemical or a UV light, P53 detects it. It halts cell division. It slams on the brakes and calls in repair enzymes.
And if the damage is too catastrophic to fix?
P53 makes a ruthless decision. It triggers apoptosis, organized cell suicide. It dismantles the damaged cell from the inside out so it can be absorbed. It sacrifices the broken cell to save the whole body.
But in Li-Fraumeni syndrome, a patient is born with a fundamentally broken emergency brake.
Yes, every single cell carries a defective copy of TP53.
So when random DNA damage happens in a muscle cell, the cell doesn't stop. It doesn't repair, it doesn't self-destruct, it just keeps dividing and passing the broken code on.
The quality control inspector is asleep at the wheel. That's why patients with Li-Fraumeni are at astronomical risk for multiple primary cancers at very young ages. Breast cancer in their 20s, bone cancer, soft tissue sarcomas.
It's terrifying, but it perfectly illustrates tumor suppression. There's also neurofibromatosis type 1 or NF1.
Right. Patients with NF1 develop hundreds of benign soft tumors along their nerves called neurofibromas,
Usually harmless, right?
usually just cosmetic. But because of the genetic instability, there's a looming risk that one of these benign tumors will undergo malignant transformation and evolve into a malignant peripheral nerve sheath tumor.
And finally, familial adenomatous polyposis, or FAP. We usually associate that with colon polyps and colon cancer, but it's deeply linked to desmoid tumors.
Desmoid tumors are fascinating. They exist in this gray area. They're incredibly aggressive, deep fibromatosis tumors.
Meaning they arise from fibrous connective tissue, and they're technically classified as benign because they don't metastasize to the lungs, right?
Right, but they are locally destructive. They act like low-grade sarcomas,
Yeah.
aggressively invading surrounding muscle and destroying local anatomy.
But what's truly revolutionary isn't just identifying these inherited syndromes, it's what we find in the sporadic random sarcomas, the genetic translocations.
Understanding translocations is like reading the source code of a computer virus.
Let's break this down because pathology reports read like complex algebra. Synovial sarcoma is TX18, creating the SS18-SSX fusion protein. Myxoid liposarcoma is T1216. Ewing sarcoma is T1122.
To a layperson, it's just numbers and letters.
So let me try an analogy to explain what a chromosomal translocation actually is. Imagine the nucleus of a cell is a massive manufacturing factory.
Okay, I'm with you.
Inside the central office, you have the chromosome's 46 massive instruction manuals for building every protein in the body. A translocation is a catastrophic clerical error.
A physical breakage.
Exactly. An earthquake hits the factory. The manual for the quality control supervisor badge falls and rips in half. At the exact same time, the manual for the mass production override switch also rips in half.
Oh, this is going to be bad.
Right. The workers panic. They pick up the torn pages, but instead of taping the supervisor manual back together, they accidentally tape the first half of the supervisor manual directly onto the second half of the mass production manual.
They glue two different blueprints together.
So now the assembly line reads this Frankenstein manual. It starts building a normal supervisor badge, but halfway through, the instructions switch. It attaches the supervisor's badge directly onto the mass production override switch.
And the result is a mutant protein that permanently locks the mass production switch in the on position. The cell receives a continuous, unstoppable signal to divide. That unstoppable factory is the tumor.
Exactly. Is that a fair way to describe it?
It's a phenomenal way to visualize it. Let's look at the classic example, synovial sarcoma and the TX18 translocation.
The lowercase t stands for translocation.
Right. And the X and 18 denote the chromosomes involved. So in a single cell, chromosome X and chromosome 18 both physically break. The DNA double helix snaps.
And when the repair enzymes try to fix it, they swap the pieces.
They glue a piece of chromosome 18 onto chromosome X and vice versa. It takes the SS18 gene from chromosome 18 and fuses it directly to the SSX gene from chromosome X.
Gluing the supervisor badge to the override switch.
Precisely. It creates a mutant fusion gene that does not exist in nature. The cell reads it, produces a mutant fusion protein, and that protein acts as a permanent on switch for cellular division.
And from a clinical standpoint, this is incredibly cool. Pathologists use these exact genetic typos as smoking guns.
Decades ago, they just looked at the shape of the cells under a microscope. Oh, it looks spindle-shaped. Guess it's a fibrosarcoma.
But morphology is too imprecise. Now we use molecular diagnostics, immunohistochemistry.
It's a way of forcing the cells to reveal their hidden identities. Let's say you suspect a leiomyosarcoma. You take antibodies designed to stick only to smooth muscle actin.
A protein found only in smooth muscle cells.
Right, you attach a chemical tag to these antibodies that will glow fluorescent green, wash the tumor slice with them. If it glows green, you know the cells are producing smooth muscle actin.
They're reading the hidden protein barcode on the cell surface, like S100 for nerve sheath tumors, or Desmin for skeletal muscle.
Exactly. And they go even further with next-generation sequencing, or a technique called FIESH, fluorescence in situ hybridization.
They physically look for the broken instruction manual, the exact X18 translocation, and if they find it, the diagnosis is 100% confirmed.
No guessing. The barcode is read. And knowing that exact typo dictates the patient's entire future, how aggressive it is, what chemo might work, targeted therapies.
Which brings us back to the patient in the examination room. How does the doctor physically evaluate the leg? The guidelines outline a specific physical detective work.
It starts with inspection. Size, location, skin tethering. Are there prominent engorged superficial veins over the lump?
If the veins are huge, that's a bad sign.
Very bad sign. It means the tumor is highly vascular. It's sucking up a massive blood supply to feed its rapid growth, forcing those superficial veins to work overtime.
They also check for ulceration, where the tumor has literally eroded through the skin from the inside out. Then comes palpation, feeling the mass.
Palpation is an art form. A benign lipoma feels soft, doughy, and you can slide it around under the skin. It's mobile.
But a sarcoma feels hard, like a piece of wood or a dense rubber ball buried in the muscle.
And crucially, it is fixed. It doesn't slide around. It's lost its boundaries and woven itself into the surrounding muscle and fascia. It's anchored down.
The doctor also does a neurovascular exam, checking foot pulses and sensation. Because if the foot is numb, that hidden tumor has grown so massive it's crushing the sciatic nerve.
Exactly. Which brings us to a major divergence in cancer behavior. This is a paramount examination pearl. Most sarcomas spread through the blood, hematogenous spread.
Right. If you read about breast or colon cancer, they spread through the lymphatic system. Lymph nodes act like biological toll booths.
But soft tissue sarcomas skip the lymphatic toll booths. Lymph node metastasis occurs in less than 5% of cases. They merge straight onto the interstate expressway. They've seen this bloodstream.
Why do they do that?
Because mesenchymal tissues require a rich blood supply. And sarcomas secrete chemicals to build new blood vessels directly into the tumor. They're surrounded by a high-pressure network of veins.
So a rogue cell just drops directly into a newly formed vein and is instantly swept away. Now, there are a few exceptions that do spread via lymph nodes.
The mnemonic is SCARE: synovial clear cell sarcoma, angiosarcoma, rhabdomyosarcoma, and epithelioid sarcoma.
SCARE. Got it. But for most, the blood highway is the route, which raises a vital question. Where does a cell entering a vein in the deep thigh ultimately end up?
It's a lesson in fluid dynamics. Deoxygenated blood from the leg travels up to the pelvis, empties into the inferior vena cava, and dumps directly into the right side of the heart.
And the heart pumps that blood straight into the lungs to pick up oxygen.
Exactly. In the lungs, the pulmonary artery branches into millions of microscopic hair-thin capillaries, often only wide enough for a single red blood cell to squeeze through.
The lungs act as a giant biological sieve.
Right. And cancer cells are larger, stiffer, and stickier than normal red blood cells. So that rogue cell shoots into the lungs and instantly gets wedged in those tiny capillary beds.
It gets physically stuck, burrows through the wall, and starts a new tumor. So the lungs are the most common destination.
Which explains a massive mandate in the clinical guidelines. A CT scan of the thorax is absolutely mandatory. You cannot just focus on the leg.
If the chest CT is clear, you aim for a localized surgical cure. If it shows nodules in the lungs, the disease is metastatic and the whole paradigm shifts.
Exactly. So we've done the exam, checked the lungs. Now we reach the most critical section, the cardinal sin of surgery.
The strict stepwise approach. Step 1, MRI. Step 2, core needle biopsy. Step 3, histopathology. Step 4, staging. Step 5, definitive surgery.
But the text drops a massive warning here.
Yes. Never perform a random, unplanned excision. It is viewed as an absolute tragedy in surgical oncology. But to a patient, it seems counterintuitive. If I have a lump, my first instinct is, cut it out right now. Why is grabbing a scalpel and shelling out a lump without imaging a catastrophic error?
Imagine an unplanned excision, like a bomb squad, dealing with a suspicious package on a subway platform. If they just blindly yank the first red wire they find, the bomb detonates. Massive collateral damage.
A sarcoma is a biological bomb.
Exactly. When a surgeon tries to quickly shell out what they think is a benign lipoma, it doesn't come out cleanly like a grape. A sarcoma is actively invading surrounding tissue.
It has a pseudocapsule made of microscopic tumor fingers.
Right. When they forcefully shell it out, they violently tear through that pseudocapsule, they cut directly into the tumor, and they spill millions of microscopic cancer cells all over the healthy muscle, the surgical gloves, the instruments.
The bleeding literally washes the cancer cells throughout the surgical bed. They contaminate the entire area. They detonate the bomb.
And the consequences are dire. It vastly increases the rate of local recurrence. And when the patient gets referred to a dedicated sarcoma specialist, the specialist is faced with a nightmare.
Because they don't just have to remove the tumor anymore. They have to do a massive cleanup surgery, cutting out the scar, the whole tunnel the first surgeon dug, and all the contaminated muscle.
Sometimes the contamination is so bad, it turns a salvageable leg into an unavoidable amputation. That's why step 1 must be the MRI, the bomb squad's advanced X-ray.
Why is MRI superior to a CT scan for the leg?
MRI uses powerful magnetic fields to create incredibly detailed, high-contrast images of soft tissues. It distinguishes between fat, muscle, nerve, and tumor perfectly.
It provides a 3D map of the bomb. It shows if the tumor broke through the fascia, if it infiltrated the muscle, and neurovascular invasion.
Right. It shows the surgeon exactly how close the tumor is sitting to the sciatic nerve, allowing them to meticulously plan the operation safely.
Which leads to step 2, the core needle biopsy. Getting tissue to read the barcode, but the guidelines are strict. Avoid open surgical biopsies. Preferred, core needle biopsy.
An open biopsy causes massive contamination. A core needle biopsy uses a hollow needle pushed through the skin directly into the tumor. When pulled out, it extracts a tiny solid cylinder of tissue.
A perfect microscopic core for the pathologist, but there's a catch, and this blew my mind. The guidelines state, the biopsy tract must be meticulously planned so it can be completely excised during definitive surgery.
It's one of the most rigorous rules in surgical oncology. Think about the mechanics. You push a needle through healthy skin, fat, and muscle into a highly malignant sarcoma.
It scoops up the cancer cells, and as you pull it out, you're dragging cancer cells with you.
Exactly. The physical scraping leaves microscopic tumor cells in its wake. The entire 3-inch path the needle took is now a contaminated zone. The biopsy tract.
A microscopic trail of seeds.
Right. If you leave that tract inside the patient, those seeded cells will grow into new tumors along the needle's path.
So the final surgeon has to completely remove that entire biopsy tract. They have to draw an ellipse around the skin puncture and carve out a solid cylinder of tissue down to the tumor.
Yes, they incorporate the invisible ghost track of the needle into their final surgical blueprint.
That is incredible. And it means the person doing the biopsy, usually a radiologist, can't just stab the leg from whatever angle is easiest.
No, if they place the needle in the wrong spot, they create a contaminated tunnel the surgeon can't reach without destroying the leg. A poorly placed needle can force an amputation.
The radiologist and surgeon have to agree on the exact angle beforehand. That level of multidimensional chess is astounding. Which brings us to step 5, the masterful extraction.
Definitive surgery. It's the cornerstone of treatment, and it must be handled by a multidisciplinary tumor board at a dedicated sarcoma center.
The surgeon, medical oncologist, radiation oncologist, pathologist, radiologist, physiotherapist, all of them.
Decades ago, the standard treatment was simple. Amputation. They chose survival over function.
But now the goal is limb salvage surgery combined with radiation. Save the life and save the leg. But how do they know they got all the cancer out?
Surgical margins. The goal is an R0 resection. R0.
Meaning microscopically negative margins. The surgeon removes the tumor, completely encased in a thick envelope of healthy tissue.
They carve a moat of healthy muscle around it. The pathologist then paints the outside surface of the tissue with brightly colored ink.
And when they freeze it and look under a microscope, if there are healthy cells between the edge of the tumor and the ink line.
That's an R0 resection. No tumor cells at the inked edge. It yields the best prognosis.
But there are R1 and R2 resections.
Right. R1 is microscopic residual disease. The cancer cells touch the ink line. It implies the scalpel sliced through tumor cells, leaving half of them in the patient.
And R2 is gross residual disease, where the surgeon had to knowingly leave a physical chunk of tumor behind, usually because it was wrapped around a vital structure like an artery. This sounds like an agonizing high-wire act. If the goal is R0, isn't it risky to try to save the limb? How does a surgeon balance taking enough tissue to guarantee an R0, but leaving enough nerve so the limb still functions?
It's the central tension of sarcoma surgery, a negotiation between life and quality of life.
Say the tumor is resting right against the massive sciatic nerve.
Exactly. The surgeon has a split-second choice. Sacrifice the sciatic nerve, guaranteeing an R0 margin but leaving the patient with a paralyzed foot drop for life, or meticulously try to peel the tumor off the nerve, saving function but risking an R1 margin.
It's an immense burden, and that tension is exactly why unplanned excisions ruin outcomes. If the first doctor detonates the bomb, the margins are blurred, and that delicate negotiation is obliterated.
Exactly. It's why patients must be managed by super specialists. Now, sometimes surgery isn't enough. We turn to the adjuvant arsenal.
Treatments given in addition to surgery. The guidelines break down radiotherapy. You use it for high-grade lesions, large tumors, deep tumors, or close margins.
Radiation uses high-energy X-rays to generate free radicals that physically shatter the DNA inside the cells in the surgical bed. Cancer cells can't fix the shattered DNA, so they die.
But the guidelines introduce the radiation timing paradox. Preoperative versus postoperative radiation, and they have profoundly different consequences.
Yes, both are valid, but they affect the body very differently.
Let's use an analogy. Imagine you're a carpenter building wooden furniture. The wood is infested with termites, the cancer cells. Radiation is a toxic chemical spray.
Okay, I like where this is going.
Preoperative radiation is like soaking the raw wood in harsh chemicals before you cut and nail it. It kills the bugs, but it warps the wood, makes it brittle and soggy.
Exactly. From a medical standpoint, pre-op radiation allows a smaller radiation field and a lower dose, but it results in significantly more major wound complications.
Because you're asking a surgeon to operate on tissue that was just blasted with radiation.
Right. The microscopic blood vessels are scarred shut. The skin lacks the resources to heal. The massive incision might just break open or get infected.
But the alternative, postoperative radiation, is building the furniture first with raw, healthy wood. It goes together perfectly. The wound heals beautifully in 2 weeks.
Because the tissue is pristine.
Right. Then you douse the finished furniture in the harsh chemicals.
And that leads to severe long-term costs. Because the surgical bed is now larger, the radiation oncologist has to treat a much wider area with a higher dose to penetrate the scar tissue.
Which leads to radiation fibrosis.
Yes. Over 5 to 10 years, the healthy muscle slowly turns into dense, woody scar tissue. The joints freeze up. The patient gets a severe limp and chronic swelling.
It's a brutal choice. Immediate wound breakdown versus relentless long-term joint stiffness.
Which is why the multidisciplinary board exists. They have to decide which poison is the safer bet for that specific patient's lifestyle.
Okay, so that's local treatment. But what about the systemic threat? Rogue cells on the blood highway. The text mentions chemotherapy, but with a massive caveat. Not all sarcomas respond equally. Adult soft tissue sarcomas are notoriously resistant to chemo.
Yes. Traditional chemo drugs are like carpet bombs. They poison rapidly dividing cells. That's why they damage hair and the gut lining.
But mesenchymal tissue turns over slowly.
Exactly. Low-grade sarcomas grow sluggishly, so they just ignore the chemo. But there are exceptions. Rhabdomyosarcoma, synovial, and Ewing sarcoma are highly sensitive because they divide rapidly.
But for the vast majority that resist chemo, we've had to put down the carpet bomb and pick up the sniper rifle. Targeted molecular therapies, drugs like pazopanib and imatinib.
Targeted therapies exploit specific molecular vulnerabilities. Take pazopanib. We said sarcomas secrete VEGF to build new blood vessels.
Angiogenesis.
That's right. Pazopanib is an angiogenesis inhibitor. It blocks the receptors on the blood vessels, making them deaf to the tumor signals. It literally chokes off the tumor's blood supply, starving it from the inside out.
Wow. And imatinib revolutionized the treatment of GIST, gastrointestinal stromal tumors. GISTs are driven by a mutant protein receptor stuck in the on position.
And imatinib is engineered to fit perfectly into that mutant receptor, like a key jamming a lock. It completely shuts off the divide signal.
Identifying the broken gear and jamming it, the text also mentions immunotherapy, using checkpoint inhibitors to strip away the tumor's chemical camouflage so the patient's own immune system attacks it naturally.
It's a highly active area of research. But despite all these incredible weapons, the daily reality for a patient is incredibly heavy.
The final section outlines the long game: prognosis and survivorship. Waking up from surgery and hearing, "We got it all," is just the end of the first chapter.
The clinical literature outlines prognostic factors, size, depth, margins, but the most important prognostic factor is the histological grade.
Grade is what the cancer looks like under the microscope, a measure of aggression.
Exactly, scored 1 to 3. A grade 1, low-grade sarcoma looks somewhat orderly. It divides slowly. The main risk is local recurrence.
But a grade 3, high-grade sarcoma.
Under the microscope, those cells look chaotic and monstrous. They divide explosively. They have a massive potential for hematogenous spread to the lungs.
And because of that invisible risk, survivorship is fraught with challenges. The text lists brutal complications: local recurrence, lung metastasis years later, functional disability, lymphedema, radiation fibrosis, nerve pain.
The physical burden is heavy, but the psychological weight of the follow-up surveillance is immense. The vast majority of recurrences happen within the first 5 years.
The 5-year shadow.
Yes, the surveillance is unrelenting. Every few months, physical exams, MRIs of the surgical bed.
And the most terrifying part, regular chest CT scans to watch the lungs. Lying in that scanner, waiting an agonizing week to find out if a tiny capillary captured a rogue cell.
The scanxiety is unimaginable. Every ache in their leg, every cough, every time they feel a piece of scar tissue, the terror rushes back.
The fear that the bomb was never fully diffused.
That trauma is exactly why the multidisciplinary approach is about holistic quality of life. Physiotherapists, pain management, psychological support, carrying the patient through that 5-year window.
So as we synthesize this massive amount of information, let's bring it back to the takeaways. If you are a medical student, a resident, or just someone who wants to be informed, you walk into a doctor's office with a lump.
But now you know about the deep mesenchymal scaffolding.
You know the red flags. Large, deeper than the fascia, growing steadily, painful, or recurrent.
If it meets any of those criteria, it is a sarcoma until science proves otherwise.
And clinicians know the golden rules. Never grab a scalpel first. Never do an unplanned excision. Map the terrain with an MRI. Confirm the exact molecular barcode with a meticulously planned core needle biopsy. Stage the disease with a chest CT.
And in the OR, negotiate the agonizing balance of limb salvage to achieve an R0 resection. Because the very first operation is the best and sometimes only opportunity for a cure.
But I want to leave you with a forward-looking thought that builds directly on the molecular genetics. We visualize the TX18 chromosomal break in synovial sarcoma.
Right, where the supervisor's badge gets glued to the mass production override switch.
Currently, our best response to that microscopic typo is macro-level trauma. Massive surgeries, DNA-shattering radiation, targeted drugs.
But as science maps these typos perfectly, we are standing on the threshold of a new era. CRISPR gene editing technology.
Which raises a profoundly provocative question. Will there be a day in the near future where the structural beams of our bodies can be repaired directly at the genetic level?
Could we theoretically engineer a viral vector, deliver it directly into a deep synovial sarcoma, and have it act as a microscopic editor?
Could it find the exact TX18 translocation, use CRISPR to chemically unglue the supervisor's badge from the override switch, and seamlessly stitch the chromosome back to normal?
Just tell the cell to revert to normal, curing these massive tumors without ever needing a scalpel or radiation beam.
That is an absolutely incredible thought to hold on to. The idea that this terrifying surgical challenge could one day be solved by simply correcting a microscopic typo.
It all comes back to that initial moment in the exam room, like that painless lump.
The next time you or a doctor feels a soft, slowly growing mass, you won't just immediately dismiss it as fat. You'll pause. You'll visualize the hidden, intricate structural foundation of the body. You'll consider the microscopic genetics firing in the dark.
And you will treat that silent swelling with the profound respect, deep caution, and rigorous scientific curiosity that it truly demands.
Thank you for joining us on this incredible journey, from the bedside to the genetic barcode to the operating room. We will see you on the next deep dive.